Recording. Okay, so thank you for joining us today. Dr. Thilo Hackert from Heidelberg. We'll be talking about complication management in pancreatic surgery. Thank you for joining us for the third time, Dr. Hackert, and the floor is yours.
Hisham, thank you very much for the invitation again. It's always my pleasure to be with you either online or maybe in person, and whatever is suitable. So this evening, the topic is complication management in pancreatic surgery, which is of course difficult topic. So I will try to give you some ideas what we do in Heidelberg and also why we do this. Now, if we start to talk about this, you know, pancreatic complications are always like this. You start with a little complication, then there comes the next complication, the next complication, and the next complication. So this is always a chain of complications, and you have to interrupt with this very early. Otherwise, you will probably lose your patient. So when you deal with these complications, it's not about surgery. Usually, you don't need surgery for complication management. I will come back to that later. Usually, you need a good ICU unit, you need good anesthesiologists, you especially need a good interventional radiology, and after all, when everything fails, then you need surgery. But this is the end of the chain, so probably the last thing you would do. Now, why do we talk about this? Because we have a high rate of complications when we do pancreatic surgery. This is some rather old paper, 15 years old now. You know that you have a morbidity in Whipple operations of approximately 50%. Most of them are Clavier-Dindo 1, 2, 3, so they are rather mild, but at least they have an impact on the hospital stay. And the problem is they can escalate to more severe complications and can even lead to fatality for the patient. Now I just want to deal a little bit with these 5 topics: the risk factors, the markers, fistulas, hemorrhage, and delayed gastric emptying, the classical pancreas complications. Now, the risk factors, all of you know, this is a soft pancreas, this is a small pancreatic duct, this is an old patient with a high BMI, with a fatty pancreas, which you have to suture somewhere very low in the body. Then you have some things like renal failure, and preoperative bile duct stenting is, of course, the complication triggering factor as well. Now, for the morbidity, you see that there has been a lot of investigations about the pancreatic tissue, soft tissue, and the duct diameter. We have tried to establish a very simple classification for that, and we've called this a pancreas A, B, C, and D, which means if you have a hard pancreas with a large duct, there will nothing happen. You have a very low fistula rate. B is a hard pancreas with a small duct. C is a soft pancreas with a large duct, and D is a small duct and a soft pancreas, which means it's the most challenging situation. And I think this classification is very simple to apply, A to D, and it doesn't mean that you have to think about it very differentiated. You just see this pancreas is going to be a problem, this pancreas is going to be easy. Okay, so now what are the other risk factors besides the pancreas? This is of course been investigated numerous times: long surgery, high blood loss or a lot of transfusions, multivisceral pancreas resections, and of course, and this is very old knowledge in the meantime, a low volume center. These are just data that are pooled from some studies that have been published. Less than 6 pancreas per year, this is high morbidity and also mortality. If you have maybe like 20, this is okay. 20 to 30 is okay. When you have more than 40, you will improve and your morbidity and mortality will decrease, and especially the mortality. Not the morbidity, but you can deal the morbidity. And I will come back to that at the end of my talk. Now, do we influence this by the type of operation when we do this open or minimally invasive or robotically? Does this in any way have an impact on surgical morbidity? When you look at the data of this very important or very big analysis here, you see that the pancreas-specific morbidity is about the same in terms of fistulas, in terms of bleeding, in terms of delayed gastric emptying. The only thing that is a difference is the wound infections. Of course, this is better, minimally invasive or robotically. And potentially the length of hospital stay might be reduced. Length of hospital stay is not a complication, but it's nice for the patient. So now, how can we recognize the complications? We have investigated this quite a long time ago in Heidelberg, the markers of septic complications for pancreatic surgery. How can you recognize this? And we saw in 700 patients, when we analyzed the complications, we had a total incidence of any septic complication, which means the dangerous complication, 13%, which includes the complicated fistulas, abscesses, complicated wound infections, pneumonia, cholangitis, all of these things. And the only marker that works is the CRP level, which means when you have a CRP of more than 140 on the 4th day after the operation, this is predictive that there is something going wrong. The leukocytes, temperature were not predictive, although everybody uses this. I know we also use this, of course, but whenever you have a CRP of 140 on the 4th day after the operation, this has a sensitivity and specificity. This is quite okay. But whenever you have this, just keep in mind, look for the focus, look aggressively for what is underneath, which means you check the wound, you check the urine, you do the X-ray of the chest. This is unpredictive. Then very liberally go to a CT scan and check what is going on in the abdomen, because this is the most likely focus the patient will have. Now, of course, the most frequent and potentially the most dangerous complication is the fistula. I just want to give you some overview on the history and the management. Now, going back some almost 20 years ago, you had in the literature 26 different definitions. What is a pancreatic fistula? Every center, everybody around the world just said a fistula is this, a fistula is that. We define it like those. So the incidence in the reports was between 3 and 45%, which is of course not science you want to make. So there was a strong need for a standardized definition and a consensus on what is a pancreatic fistula. And therefore, Bassi from Verona came up with this definition in 25, which was very simple. You have any brain discharge, 3 times elevated amylase levels. This is a fistula on post-operative day 3. Everybody agreed, it was very simple. And then there was a kind of a grading, which means you have A, B, and C, the little fistulas, the intermediate fistulas, and the severe fistulas. So this was the definition in 25, which was accepted around the world. And you see, when you look into the Medline, who used this definition, this was hugely increasing until 2016. Every manuscript, every paper had to report the fistulas in this ISGPF definition by that time. However, this was then, of course, evaluated afterwards. Is this worth doing it? And this is some series from Pennsylvania University, Chuck Vollmer, and you see that between no fistula and grade A fistula, this is absolutely equal. You just have the drain in place a little longer. You have no actual consequence for the patient, no CT problem, no drain removal problem, no antibiotics, nothing else. So probably no fistula, and by that time, grade A fistula is about the same. This was also reflected in terms of economy, health economy, which means the hospital costs for a patient with no fistula and a so-called grade A fistula are exactly the same, $18,000 for treatment in the US. Another thing that we did a little bit later was checking what is the difference between B and C fistula. Is this an accurate difference? We evaluated this in 400 patients, if the B and C fistulas are really different from the 2005 definition. When you look at this and you really strictly classified this in our collective, we had an extremely high percentage of C fistulas. You see 70% of C fistulas, which was actually triggered by the CT drainages, because the CT drainages were classified as a type C fistula in the original definition. What was the outcome? You see an interventional drainage by CT scan percutaneously. Did, of course, do some harm to the patient. It is not nice to get this, but in the end, you have zero mortality if you only have a CT placed drainage in this patient. Whenever you have a reoperation, you have a mortality of 36%. Both of these were classified as type C fistulas by this time, and the prognosis was, of course, extremely different. Therefore, we proposed by that time in 2015 that we should revise this classification and that interventional drainage by CT scan should only be a type B fistula, but not a type C, and that you should only term this a type C when there was a reoperation or a fistula-associated mortality, and this should be clearly differentiated from a type B fistula. This was adopted by the ISGPS finally. Claudio Bassi once again did the work, and he proposed the new revised classification then, and therefore the type A, was principally abolished. It was only called a biochemical leak. B were most of the fistulas, which led to some intervention, some change in management, some antibiotics, things like that, but extremely important, not to organ failure, to reoperation, or to fistula-associated death. And this was the big difference, what the revision of the POPF definition of the ISGPS did. And I think this is much better today, that you really have no type A fistulas anymore. Most of them are probably type B, you can handle them, but type C is has become rarely, and this is only organ failure, death, or reoperation. So this update in 2016 was also well accepted. It started in 2017 with the citations you see, and until 2022, 2021, this has been cited approximately 380 times a year. So everybody has agreed with this definition because it was just kind of logical. Now, how can we prevent the fistulas? Also, some older study from Verona, from Claudio Bassi once again. When you have a low amylase in the lipase in the drain, you can remove that very early, up to day 3. You should not keep the drainage any longer, because otherwise you have a high risk of afterwards becoming a fistula. Not if you have a high risk drainage output, which means amylase more than 5,000, then of course you might keep the drainage. So this is something you can prevent. The other thing is, do you need a drainage anyway? And of course, this study was done in our institution together with Dresden in Germany, if you put in a routine drainage after a ripple or not. And finally, we saw that the drainage does not prevent a fistula. Actually, when you put in a drainage, you have a higher rate of fistulas and therefore also some higher associated complications, which means routinely a drainage is not recommended. But of course, everybody has to decide himself. And of course, you have to be aware of how to manage a fluid collection. If you have a 24/7 interventional radiology that can put in a drainage anytime, 3 a.m. at night, it's fine. We had some problems with the US where they had hospitals out in the rural areas. They had no interventional radiology. They could not put in a drainage, and they had a higher mortality when they left out the drain. But I just want to tell you, the drain does not prevent a fistula. It is not a protective factor. Now, what else is triggering a severe fistula? We saw that the bacteria in the bile duct, of course, especially after stenting, do this. And when you have any Escherichia coli in that, this is a very high probability of a type C fistula. And the worst thing that you can have is Enterococcus. This is the thing you should treat. And this means whenever you have this in your bile duct cultures, you should prolong your antibiotic treatment just to prevent any severe, especially type C fistulas. And this is once again shown here. The worst thing you can have is a faecium and candida, and we have found candida in some of the patients. And whenever you have this, this is a high risk factor, and this should be treated aggressively to prevent a complicated fistula whenever you find this in your bile duct cultures. Now, how to treat the fistulas? Everybody knows we should treat them interventionally in the first place. Very old paper, almost 20 years now, from John Cameron's group. You see interventional radiology, 12% in the patients that they operated with a Whipple. This was for some fluid collection. This was for some anastomotic leakage. This was for some bleeding. And when you further look into this data, you see that a reoperation was only required in a very low percentage of patients when you did the first management with interventions. And this is what is the standard of care today, of course. First is interventional radiology. Last is operation for any of these complications. This is just an example. You have a collection, you put in a drain, you do a fluoroscopy, you see there is, of course, a fistula with some leakage to the bowel, but when have the drain put in, this is fine. Another thing that we like to do in the meantime, we have just started recently, is a transgastric drainage. This is, of course, especially suitable for distal pancreatectomy. You have stapled your pancreas here. On day 5, 7, 8, you have a collection here. Your endoscopist goes in, does the ultrasound, and does a drainage, as shown here, transgastric. And of course, this is very comfortable for the patient because it does not have an outer drainage, not a percutaneous drainage, just into the stomach. And then you leave this for 2 weeks in the first place. You do an endoscopic ultrasound again. When the collection is gone, you try to take it out. If there is still some fluid coming out, you can leave it in up to 6 weeks. And the good thing is you can send the patient home with this. This is not a percutaneous drainage, which needs some more care for the drainage. It's just an internal drainage. So I think this is something that has evolved and that should be, I think, promoted in the future. Now, what about taking out the pancreas when you have a complication? I just want to show you some data and some pictures on this. Why do we not like to take out the pancreas? Because this is associated with a very high mortality. These are data from Heidelberg, very old in the meantime, 15 years. You see an elective total pancreatectomy mortality is okay. If you do an emergency completion pancreatectomy for fistula, for bleeding, for whatever, 40% mortality. We should not do this unless we are really forced to do this. So what is the data from other centers? This is not only Heidelberg. You see, this was a systematic review published 3 or 4 years ago from all of the centers around the world. Mortality for emergency pancreatectomy was 42%. So this is the number or the figure you have to keep in mind. When you do a reoperation in an emergency setting, 40% of your patients will die despite you take out the pancreas. And therefore, I think the algorithm should not be surgery first. It should be anyway drainage first. Maybe you can preserve the pancreas, and the utmost step is the completion pancreatectomy when there is no other possibility. Now, what are the possibilities you have when you have a complicated fistula? These are just some schematic drawings from a publication some 5 years ago. You see, you can disconnect the anastomosis and you can drain the pancreas. You can disconnect the anastomosis and leave the pancreas open. I think this is not a good option. You can disconnect, close the pancreas. From my point of view, not a good option as well. You can do an internal, like a bridging drainage. You can take out the pancreas, or you can try to redo the anastomosis into the stomach. Actually, what we usually do is either this or that. You keep the pancreas, drain it externally, or you take out the pancreas. I want to show you some examples of this. This is a pancreas anastomosis, day 5 or 6, I don't remember exactly. Patient was septic, patient was really clinically bad. We went to the OR, you saw something like this. The pancreas anastomosis is simply black. Now this is 3 a.m., patient is not stable, anesthesiologist is not happy, you are not happy, you decide take out or not take out, you decide to take out. What you find is something like this. You see the first 2 centimeters are necrotic. The rest is completely okay. But you cannot estimate this at the first glimpse at the operation. So this is clearly a patient where you should preserve the pancreas, put in some external drainage as shown here. Pancreas is perfused very well until the end. Spleen is perfused very well. The vessels are open. You can clearly preserve the pancreas. Same scenario. You open the abdomen, you see this. You take out the pancreas and you find something like that. This is a completely necrotic pancreas, which will never heal. This needs to be taken out, but it's very difficult from my experience to evaluate this properly at the first view at the pancreas, especially in this always emergency situations where you take the patient to the OR and he is not stable, and then you have to decide what to do. So you might do some wrong decisions at that point. I could really understand if this happens. Now, who needs really the completion pancreatectomies? These are once again data from our center. We could just recently publish this year, 4,000 Whipples. We had a completion rate of 3%. And who would really need this completion pancreatectomy? You see from the baseline, this is all the same in the patients with the completion pancreatectomy, except for the indication. The ones most frequent were the distal cholangiocancers. They have a soft pancreas, everybody knows. This is a difficult anastomosis. They have a tumor in the background, and these are the patients that like to get this kind of complications for remnant pancreatectomy. The other thing is that the bleeding is the most important thing, which means the bleeding is the most life-threatening event when you do a remnant pancreatectomy. And you can see this here reflected in the mortality. Mortality in this bleeding group is 46%, even higher than what I told you before. And this is the highest rate of mortality that we see. And this is much higher than you have a leakage or you have a pancreatitis of the remnant. So these are the most challenging situations. You have a bleeding, maybe some interventional management before, not successful, take it out, high risk for the patient. Now, how can you recognize these complications up front? You can only recognize if there's a pancreatitis. If we have an early remnant pancreatitis, a necrotizing remnant pancreatitis, you have a very high amylase output on the drain, and you have a very high serum CRP, which will not decrease. You remember the markers of the complications, but this is not 140. This is even higher. This is 205, 240 on day 4 to 5. And these patients, I think you should very liberally take to the OR again and remove the pancreas, because this will be a picture like I showed you in the second case with this black necrotic pancreas. Now, how do we do it? Actually, we do not routinely place drains. We place drains in maybe 50% of the patients. If you put a drain, take it out early. We do not do octreotide in all of the patients. We do it selectively, sometimes in the type 4 or type D pancreas. You remember small duct, soft tissue. And when you have a high CRP on day 3 or 4, and this is not coming down as you would accept, then you do a CT scan immediately and you manage the fistula or the collection that is behind. So therefore, watchful waiting if you can. You have to do the cultures that you have from the abdomen, and a open revision, a surgical revision, a completion pancreatectomy, only very selectively, because you have the high mortality, only uncontrolled sepsis, only uncontrolled bleeding, then you should do this. So now, some very short things on bile leakage. You have a definition of the ISGPS. I think all of you know that. We don't need to discuss this in detail. How do we manage this? This is some example from our institution. We had this in most of the cases after Whipple procedures. We have some bile leakage, sometimes also after total pancreatectomy, but not that often. Whenever you have this, the first thing is PTCD, which means the radiologist puts in your drain here. He does this PTCD over the anastomosis that is leaking, and then he can really close this leakage This takes a long time, might take up to 3, 4, 6 weeks, but in most of the cases, it's better than a surgical revision. Next thing, very briefly, chyle leakage incidence after radical surgery is maybe 10 to 15%. The treatment usually is conservatively, which means fat-free oral, some diet like this, some total parenteral, and then you have a definition again. Most of them are mild, grade A, some of them require total parenteral, and some of them, the grade C chyle leakages, require some intervention. What is the result of the intervention whenever you do this? Some data from our experience, we had these chyle leakages that need some intervention in 59 patients. And the first attempt is the lymphography. Success rate, however, is only maybe 50%. I mean, this is a try. In many patients, it does not work. The next thing that you can do is low dose radiation, which means some 15 to 20 gray radiation in the area of the presumed leak. And the last thing that we do is operative revision. I don't remember a case of operative revision within the last, I think, 10 years for pancreas. We had it for esophagus sometimes, but not for pancreas. So best thing is do radiology again. Success rate at least 50%. You can repeat this procedure. Maybe your success rate will be a little bit higher. Now, hemorrhage, I already mentioned, is of course a severe complication as well. Once again, the definition you know from the ISGPS, the early and late onset, the intra and extra luminal, and of course the grading, how much transfusion a patient needs. I don't need to repeat this, very detailed here. The surgical problems are, of course, as all of you know, the things where you have approached the vessels, the GDA, portal vein, SMV, SMA, or bladder. Of course, this should not happen. Retroperitoneum should not happen as well. And then the intraluminal bleeding along the anastomosis. Everybody has experienced this as well, is always can imagine like a intraluminal, but sometimes also a false intraluminal bleeding, because when you have a fistula and the bleeding is here, this will also come along this way and will be obvious as an intraluminal bleeding. But this is also the false one, probably the most difficult to recognize. Now, what I want to tell you is, whenever you have a bleeding, this doesn't happen upfront. This is some historic series from the Netherlands. And the only thing I just want to tell you with this paper is, whenever you have a bleeding, a massive bleeding, nearly all of the patients have a small sentinel bleeding before, which means you can predict the bleeding. When you come to the ward in the morning, you see the drain that you have put in some 5 or 6 days ago, and suddenly the nurse tells you, there's a little bit of blood in the drain. It's just 10 milliliters. It's not worrying. This is worrying, and you should act, because this is the sentinel bleeding that you have seen here. 100% of the patients have a sentinel bleeding before the real bleeding starts. Whenever you do have a bleeding, you need to do something, of course. Take the patient to the CT scan, take the patient to the ICU, and take the patient to angiography. Once again, the radiologist will help you. They will put a stent and they will stop the bleeding, which is the classical location here, the GDA. But still, when this occurs, this is again the series I showed you, mortality is not low. This is between 20 and 27%. 1 out of 4 patients may die because of bleeding. This is just some examples that you could also do. Coiling of the GDA stump. We used to do this in the past very often. In the meantime, we also prefer the stents, because these coils sometimes like to dislocate into the hepatic arteries, and therefore the stent is much better. Now, when you can do this with your radiologist, this is very successful usually. Once again, unfortunately, some old series from our center, 25 patients where we had this bleeding, 92% were successfully located with the CT scan and the angiography. And then, of course, in 95%, the radiologists were successful to close the bleeding site. 15% needed some second intervention, but still when you manage it like this, you have 20% overall mortality. And one thing that you have to keep in mind when you look at this, the median post-operative day of the bleeding is 3 weeks after Whipple. You always have some problem behind, a fistula, a septic complication. 3 weeks after Whipple, in median, the bleeding occurs, and then you have these measures that you can do, but still you have a mortality considerable. This is something I want to skip, the Reboa maneuver you need very, very rarely. And this is just our algorithm that we like to do. When you have an early bleeding, this is of course surgical. Below 24 hours after surgery, go back to the OR. But usually the bleeding is septic, erosional, fistula behind, and then you go for CT, go for angiography, stenting, embolization, and then this is usually fixed and you don't have to go to the OR, except maybe in the end for hematoma evacuation, if ever this is necessary. Now the last thing, which is the most simple complication from my point of view, is the delayed gastric emptying. Also the classical definition from the ISGPS. You all know this has been published some 15 years ago. People cannot eat, people have some vomiting. They either need 1 week, 2 weeks, or 3 weeks of nasogastric tube and cannot complete their oral intake. So this is a very simple definition, ABC grading, 1, 2, 3 weeks. And then of course you have associated with this ABC grading some complications, which means that you need in some cases some re-laparotomy, very rarely. But of course, anyway, it is an annoying complication for the patient and also for you, because every morning you stand beside the bed and say, okay, nothing better, 2 liters out of the nasogastric tube, what can we do? Actually, you can do not very much. There were a lot of attempts how to prevent DGE. And I just want to show you how this was attempted to do. Can you do this by your reconstruction? Just a meta-analysis if you do the reconstruction ante or retrocolic. Big discussion in the past, antecolic, retrocolic. You see, when you look at all the studies that have been published until 2015, and actually there have not been much more published in the meantime, you think antecolic looks quite nice. Please look at these studies. You see these are studies with some retrospective aspects, with some small patient numbers. Okay, when you look at the RCTs that have been properly done, this is these 5 RCTs, and these 5 RCTs are not significant anymore. So the diamond cuts the line. Ante or retrocolic is not the decisive thing. It depends on what you like as a surgeon. So you can do whatever you want, ante or retrocolic, DGE will probably be the same. What else can we do? We tried to resect the pylorus because everybody thought, take away the pyloric ring, this does not be spastic anymore, DGE is gone. We were very enthusiastic about this actually, because we looked at this in our collective retrospectively, and this was a big factor. Then we did the RCT, and the RCT included some 200 patients, resecting the pylorus, not resecting the pylorus. And you see the results are extremely disappointing. Everything is about the same. No significant difference, pylorus resection or not. No difference in our RCT. Then we did, of course, a meta-analysis to see if this is true or not. And when you look at the outcome DGE from the randomized controlled trials again, exactly the same, no difference. So our standard still today is preserve the pylorus. It does not affect your DGE. This is either be lucky, no DGE, or not be lucky, you have DGE. So therefore our standard will be antecolic, just because of the retrospective trend for some better thing, and you have to decide for one standard or the other. We do some erythromycin or some metoclopramide to prevent this. We take out the NGT very early, but of course we insert it very early again if necessary. We do some endoscopy on day 8 to 10 with some dilatation, and especially to rule out any mechanical problem of the operation. However, this is usually not the solution. And of course, we do some CT scan to rule out that there is some collection behind that causes the DGE. But in the end, finally, you cannot really manage the DGA other than being patent. And then patience is what you have to tell the patient, and patience is what you have to tell yourself as well. Now, the last thing I want to come to very briefly is how can we improve? And I think this is a very important study from the Netherlands. This is the so-called Porsche trial. What the colleagues did is that they included 17 hospitals nationwide in the Netherlands. And they randomized these hospitals time after time, either to do the complication management the way they had done the last 20, 30, 40 years, or randomizing to a new protocol, which was clearly communicated to the hospitals and which was available on a handy app. You see, this is happening, do this. You have a CRP of that, do this. And this was a very clever trial, I think, randomized between these 17 centers. And finally, this year, they published the results of this trial. They included 1,800 patients in this trial along the Netherlands. Nearly all of the doctors, including in the study, used the app and saw what was recommended to do according to the study protocol. You see, they had the operation. Then after day 3, the protocol started. And the app told you, do a CT scan today. They did the CT scan, or they did not the CT scan. Or the app told you, remove the abdominal drains, remove or leave in place. Then after the evaluation of the CT scan, of course, this went further. The app told you, no action, start antibiotics, do some step-up approach with percutaneous drainage, or consider surgical reintervention. And what came out was that the end point of the study, which means severe complications and death, this was kind of a composite endpoint. In the intervention group, following the app, we are living in 2022, they followed the handy app, they are doctors. 8% hit the primary endpoint. When they did what they historically did in the control group, 14% hit the primary endpoint, significant reduction. And I think the most striking thing is shown here, mortality of the patients using this standardized protocol for complication management, 3%, using what you historically did, how you learned this, how you always did this, 5%, significant reduction. And I mean, this is not so striking. 5% mortality is still a good outcome. But when you look at the rest, how they stratified the centers, they had low and medium volume centers, and therefore they reduced this by 5%. In the high volume centers for the mortality also. But the important thing is, in the low and medium volume centers, this was 50% in the end reduction. In the high volume centers, it was not that striking. But this just shows you when you have a standardized approach, you can do this by a handy app, you can do this by an SOP in your hospital, however you like to do this. You just need your standards. This complication happens, you do this, and this is your consequence. You can really do better and reduce your mortality, not your morbidity. Your morbidity you cause surgically. Soft pancreas, small duct, bad stitches, whatever. Just handle your morbidity right, your mortality drops. And then these patients, of course, did very much better. I don't want to go into the details here. I think this is too long. Just the last 2 slides. Whenever you do not do this, this is the so-called failure to rescue. And I think this is an extremely important message. You do have complications. Everybody who operates has complications. You just have to deal with them. And when you see these rather old study from JAX from the US, you have major complications. They can be handled with a very low mortality or with a very high mortality. And you see a difference in morbidity between hospitals that handle it well and the hospitals that do not handle it well is 2 times. This is still reasonable. But associated with this difference is a mortality difference of 5 times, which means 2 times, 5 times. And this is shown here. That means the risk of dying when complications after pancreatic surgery are not handled correctly is 10 times higher, and this is definitely failure to rescue. Don't abolish complications at all. That would be ideal, of course. Nobody will manage this. But handle the complications correctly, and then you will not have a 10-fold risk of mortality for the patients, but you will have a maybe equal risk of mortality. And I think with this, I have completed all of the most important complications of pancreatic resections. And of course, this is still challenging also for us. We still deal with these complications every day, and we still have severe complications. And I hope that we have a good discussion now. Thank you very much.
Thank you, Dr. Hackert. Let's start by taking some questions from the audience. We have a question from Dr. Naim.
Yes, sir. Professor Magid, can you hear me?
Yes,
Yes, I can hear you.
Thank you very much for giving me this opportunity to have a question from Professor Hackert. My question is technical related. As Professor Hackert said that they use the external iliac artery graft for the SMA when they do SMA resection. So what are the technical points in terms of taking the graft in order to prevent the limb ischemia? Because the external iliac artery ultimately it takes its name as a femoral artery of the limb. So what are the technical considerations when they are taking the graft of that artery for SMA replacement or interposition or whatever they do? Thank you.
Okay, thank you very much. This is a completely different question, but don't worry. I can tell you very detailed why we did this or why we do this. I think you may have seen the picture that I showed in some of the meetings. The first thing is, when you do have to do a graft on the SMA, you can choose the aorta as the origin, of course, which is possible, but which means you have to clamp the aorta, which is not nice for the anesthesiologist, which is for you a little bit of stressful, but it's possible, no question. But the second thing, I don't think you have a problem with the limb. Every kidney is transplanted on the iliac artery and has an arterial blood flow of 350 to 500 milliliters per minute. When you replace the SMA, the blood flow is about the same. It's about 350, 500 per minute. So I think in a healthy vascular system, you can very well put the graft on the iliac artery without risking any ischemia to the leg. And in kidney transplant, as you know, this is done every day. So I don't know that if any of the kidney recipients ever experienced some ischemia of the leg, except when you have done a technical problem with a dissection of the iliac artery or something like that. But actually, I think this is a good option, and do not go to the aorta, because the aorta always is a rather big issue to approach.
Okay, thank you, Dr. Madhat Khafaga.
You're muted.
Yeah, okay. Now,
Yes.
you hear me? You hear me?
Yes.
Okay. Thank you for your lecture. What do you think is the cause of the necrosis of the pancreas? That's one question. Because, and the other question, anyway, we will start one question. I think the necrosis of the pancreas here is due to anaerobic infection, because it didn't interfere with the blood supply to the rest of pancreas. Why necrosis occurs? Yeah.
Yes, that's a very good point. And actually, I cannot give you a complete answer to this. If you have a 2-centimeter necrosis, as I showed you in one of the pictures, this is probably a technical issue that you have damaged the vessels right at the resection margin in some way during your preparation, during your anastomosis. I think this is to be explained. But when you have this complete necrosis that I also showed you, I think this is something that is not your surgical problem. This is a very vulnerable pancreas, a very, whatever you manipulate with this pancreas will damage this pancreas. But how
I
this
think it is anaerobic infection. Clostridia infection which causes thrombosis of the vessels supplying the pancreas.
That's a good explanation. That is possible, but I think we have not examined this correctly. But this is a good explanation. Yeah. Otherwise, you have no real pathophysiology how the complete tail and body could get necrotic.
Well, the second question, or the second comment, of course, we used to have this delayed gastric emptying as you have, but we said that if we remove 60% of the stomach, the incidence will be less than 5%. We take 60% of the stomach out with the pancreatectomy, so that there is no organ to delay, because most of it is removed with the Whipple.
So you always do a classical Whipple, which means like 60% stomach removal.
Yes.
And do you see
So
any problems?
the stomach will not have any chance to dilate or to delay.
Yeah,
because it will be a conduit. It will be a conduit.
I think
not
that's
a reservoir.
Yeah, that's a possibility how you can probably manage DGE. What is the weight course of your patients? I mean, after operation, they lose 10%
No problem
of weight.
at all. I have a good series, more than 100.
So they adapt to this.
Yeah, they have no problem with weight gain or something.
Yeah, I mean,
they don't get weight loss.
Could be a good solution. You just remove the classical Whipple.
No, classic Whipple, you don't remove 60% of the stomach. You remove only the antrum.
No, in the classical Whipple, you remove 50-60%, I think, what Whipple published.
No, I'm sorry. You remove the antrum only.
Yeah, the
classic Whipple, you don't remove 60% of the stomach. No, not at all. Well, okay, I saw Dr. Fortner in Memorial Hospital doing the classic Whipple. I saw Dr. Also the chief of surgery, who had been for 15 years the chief of surgery, Memorial Sloan Kettering. He used to remove only the antrum.
Okay, so that was only the pylorus a little more.
Yes.
And what DGE did
this is the classic Whipple. This is the classic Whipple.
Okay, but what DGE did he have? What rate of
I
DGE?
removed 60% of the stomach, nearly to the lower border of the spleen.
Okay, I mean, if you have this good experience, this could be a possibility to avoid the dilation and the functional palsy of the stomach.
Yeah. Thank you.
Okay, do we have any other questions? Please, if you have a question, raise your hand. Dr. Walid.
Yes, hello, Dr. Hackert.
Hello.
Hello. Thanks a lot for your nice and interesting presentation. I would like to ask you a question regarding single loop anastomosis. How many centimeters do you leave in between the pancreaticojejunostomy and hepaticojejunostomy in routine practice?
Well, in routine practice, I leave about 15 centimeters in between. I think you should rather leave a little more space because this is usually very floppy, and I don't see a need to do this very close together, like 5 or 6 centimeters. Otherwise, this could really be relaxed, and so 15 centimeters about would be the standard practice I do.
Okay, thank you.
Any other questions? Please raise your hand if you have a question. Dr. Mustafa. Yes, Dr. Mustafa.
Thank you, Professor Hackert, for this presentation. As usual, very nice illustrated presentation. If you have a very small duct and a soft pancreas, what about to do isolated limb pancreaticojejunostomy? Is it a good option?
From my point of view, it is not, because there are 3 studies that are randomized that this double loop reconstruction does not reduce your fistula rate. So I think it does not really help Yeah, if you have a really critical pancreas, like the type D I showed you, very small, very soft, and you are really worried, I would rather take it out than do a different type of reconstruction and hope that this will be better.
No. If you have a recurrent in the distal stump, what's the option for not recurrent, positive margin in the pathological specimen?
You mean if you have the final pathology after 5 or 4 days? Yeah.
5 to 4 days post-operative final pathology.
That's a bad situation. I mean, we do the frozen section always. If this is negative and then after 5 days your pathologist says, oh, I have been wrong, I would always look to the rest. If they have 7 positive lymph nodes, if they have perineural spread, I would not do anything. I would just do adjuvant therapy. If you have R1 at the resection margin and positive lymph nodes, things like that, just go for adjuvant. If this would be a T0, N0, everything 0 tumor, and only the resection margin was positive, I would complete it. But this depends individually on the situation of the patient.
Okay, thanks a lot.
Dr. Madhat?
Yes. Okay. I disagree with you as regards drainage, because I was trained in Memorial Sloan Kettering Cancer Center for 3 years, and they don't do drainage or early removal of the drains, but they have 8% of collection, and they resorted to the radiologist, interventional radiology to drain, but I was not convinced of that. And there is also, of course, the secondary hemorrhage. I think pancreatic, there is a lot of anastomosis in this area. And this abdomen needs drainage like a generalized peritonitis. What I do, I put 2 Penrose drains on the right flank and 2 Penrose large ones, the left flank, in addition to tube drains, number 18 French. And they stayed for about 10 days to 14 days. These drains, extensive drainage, will prevent any generalized peritonitis, and will prevent secondary hemorrhage from GDP, gastroduodenal duct. That's my experience. I didn't encounter all my life any post-operative secondary hemorrhage because of a good drain.
No, that's a very good experience that you have. I can only tell you our experience, and you know, there are 3 studies on the drainage that are really randomized. 2 are negative, which is ours, and the study by Conlon, which is actually done in the Memorial Sloan Kettering in 2000, when Kevin Conlon was there. And then there was this multi-center study from the US, from Ekena, which was in 2000, I think, 11 or 13. And he had a high mortality without drainage. And I think you can extensively drain. No question about this. And you should do this when you want to be extremely safe. And you have made good experience with that. And I think the problem is, in the US, the study that failed, that was dangerous, was because they did this in some hospitals in rural areas. They have no intervention possibility. They have no drainage. They have developing a collection. They don't recognize the collection. The collection gets bigger and they don't do anything. Then it is dangerous not to drain. I absolutely agree with you. But if you have
what type of drain? The thing is that you have to get a good drainage, a Penrose drain, very big Penrose drain, the largest one, not tube drains. These tube drains will obstruct. A few hours will obstruct with clots. And so a good drainage is a good drainage with a Penrose drain, not a tube drain, because all tube drains are not perfect.
Yeah, of course.
That's why I think it is a negative study, because of poor drains.
Yeah, everybody prefers his drainage, and maybe the drain type is something that you can talk about, as you say. And if you have a good experience with the extensive drainage that you do, that's a good point. But still, there are some studies that have seen the difference in the results. So this is a matter of debate anyway.
But the drainage which they do, just a tube drain which obstruct immediately,
Yeah,
which is not
so
the perfect drainage.
The Penrose may be better. Yeah.
Yeah.
Okay, do you have any other questions? Yes, one more question.
Sir, can you hear me again?
Yes.
Yes, I can hear you.
Hello, sir, can you hear me, please?
Yes.
Oh.
Yes, we can hear you.
Yeah. As far as you were talking about the drainage, and as Professor Thilo, he is also a legend in the pancreatic surgery. But there is another legend who has retired now, Professor John Cameron of Johns Hopkins. If you see his current textbook of the pancreatic surgery and his lectures, he always had this habit of using the GP drains, 2 GP drains, Jackson Pratt, one above and one below the pancreatic anastomosis. So he always used the drains. It was his habit. So I think drainage is always, yeah, pancreatic fistula is the Achilles heel, but I think the drainage is also a very good option, and that too the extensive wide drainage. So Professor Hackert, what is your habit? How you usually proceed with the pancreatic anastomosis? Do you always do the drainage?
No, as I mentioned, I do not always do it, but I do it individually. And I mean, not routinely, but individually. And if you are not sure, if you are feeling like there could be more fluid, there could be some secretion, there could be some fistula, yes, you put in a drain. But if you have a hard pancreas, pancreatic cancer, extended, portal vein resection, the pancreatic duct is 1.5 centimeters. The pancreas is hard as a rock. I don't drain. But this is my personal preference.
Thank you, sir. Thank you. Thank you.
Okay, I don't think we have any other questions. So thank you, Dr. Thilo Hackert, for today's talk. And I hope you enjoyed the discussion afterwards.
Yes, I did. Thank you very much.
And always looking forward to, if you have the time, we would definitely want to have another talk from you in the future.
Okay, thank you very much for the invitation. Always a pleasure.
Thank you, and everyone have a good night.
Have a good night.
Bye-bye.
Bye-bye.
Bye-bye.